All right, let's get started. This is Dr. Michelle, is it Laughlin or Laughlin? Laughlin.
Yep.
She is here, this is probably her 5th year giving this lecture.
Probably, yes.
She's also one of the preceptors for the trauma service, and so some of you may get to know her a little bit more, or may get to know about her a little bit more during that service. Today's lecture is supposed to be as interactive as possible. So when she asks questions, again, if you don't know the answer, just blurt. You can still blurt something out. Something's better than nothing. So I'll let her kind of introduce herself.
And if it's a swear word, that's fine too. I sound like I have Tourette's half the time.
So I'll let her talk a little bit more about herself and get started. Thank you.
How do I get it up here? Thank you. So you're very unfortunately stuck with me for like 2 hours. So we're going to go over, the first lecture I do is a lecture that we give to all the medical students, a lot of the paramedic students, and then I've been giving it to you guys for several years now. And basically this is to sort of show you how the initial assessment of a trauma patient should happen, okay? It happens in the emergency department, and every year we get comments that the trauma lecture should be an ER lecture, not a surgery lecture, and I will argue vehemently that that is not an accurate assessment or statement. So the first part we will talk, it's a very standardized lecture, but what it looks like in the shock room, how the patient is assessed, how we decide urgent versus non-urgent, and go from there. The second lecture will be a little bit more fun. It's a lecture sorry, I can't turn that off because I am on service. It's a lecture that I wrote for our residents and medical students on my service about chest trauma specifically, including a few cases of patients that I have handled personally. So real life patients, real life imaging from these patients and stuff like that. Like Sean said, I do not like to just talk at people. That is very boring for me. It makes it very boring for you, so talk right back at me. You can swear at me too, that's fine. Anytime you need to interrupt, you have a question, because the first part will go through fast and I can't give you these slides because they're copyrighted, so I know that some of it will be kind of fast, so you'll be taking notes. Old school, we used to write things down back in the day. So at any point, if something is confusing or whatever, stop me. If I don't see you, raise your hand, shout, whatever. So what we're going to talk about first and foremost, we're going to talk about the primary assessment of a trauma patient and then the secondary assessment of the trauma patient. But throughout the lecture, what we want you to understand is the importance of getting a patient's history. People think a trauma patient's here, knowing their history isn't that important, but it's absolutely incredibly important. Understanding the mechanism of injury, high volume or high velocity injury, penetrating versus blunt, whether they fell from standing versus fall from second or third story, it's all important. MVC, whether it's high speed or low speed, whether there was rollover, whether they were ejected, all very important in terms of what I start thinking about and where my concerns lie. It also talks a little bit about how everybody in the room has a role, and if people aren't doing their role, the whole thing can break down. So teamwork is a huge deal for these patients. So trauma is the leading cause of death for people ages 1 through 44. The important thing to know is that this happens to young people, and it happens predominantly to males, because males tend to have riskier behaviors than females. It's not always true, but they tend to be a little more aggressive and a little more risk takers. The biggest thing here, though, is that disability exceeds death by a ratio of 3 to 1. So yes, I saved your life. Yes, you survived your trauma. But a large proportion of these patients do not go back to a full functional life. They do not go back to working full time, to paying their bills, to doing all of these. A lot of these people have, whether it's PTSD, whether traumatic brain injuries, horrible depression from their trauma, paraplegia, spine injuries, anything like that. Many of these people never make it back to fully functional humans. Trauma-related costs are over $400 billion per year, and these were like the 2009 or 10 numbers. It's higher now. Our skill set has gotten better. We are saving more lives, but we're also keeping more people in nursing homes and things like that. So it's a hit or miss on whether we're doing good or bad in terms of this. And there is a lack of public awareness for injury prevention. Everybody knows you should wear a seatbelt. Everyone knows you should wear a bicycle helmet, but there's a lot of other things that go on and a lot of programs that we have initiated, especially at Eskenazi, to sort of help try to minimize or decrease our recidivism in terms of, I see a lot of patients back to back, same people, same kids getting shot over and over and over. Is there some point we can intervene, we can step in and try to prevent this from happening again? And so we've started a program called Prescription for Hope that is to help with that. It helps these people who are anywhere between the ages of 16 and 35. We used to cut it off at 30, but we've decided that 35-year-olds are redeemable as well. Once you sort of get beyond that, changing someone's lifestyle is pretty difficult to do. At that point, they've already established who they are and what they're going to do. But this helps these people get back in school. It helps them get their GED. It helps them find finances to support their families, because many of them, even though they're babies themselves, have children and things like that. Helps them find food and housing and shelter and things like that to try to minimize the return rate that we're seeing. So there's a trimodal death distribution that we see. There's the patients that die immediately from their trauma. So these patients with horrible aortic injuries, bad brain injuries, things like that die immediately. We never see them. There's the patients who make it to the emergency room and die within 2 to 3 hours of arrival. So again, these are a lot of times the hemorrhagic shock patients, the gunshot to the head patients who are reasonably stable initially when they show up, but as the injury progresses and proceeds, they will lose vitals. These are the people that I lose on the table. And then more so, this group of patients, this late deaths. These are our really expensive deaths. These are the patients that made it to the ICU and then have had recurrent issues with pneumonia, ventilator-associated pneumonia, line sepsis, just a progressive brain injury that the parents or family ultimately decided they wanted to withdraw care. These are the patients that linger forever. Each ICU day is about $16,000. So every day that a patient is in the ICU, it's like about $16,000. We have patients who are up there for months at a time. So it can be pretty costly. So what this whole lecture is talking to you about is that we need to treat the greatest threat to life first. The most important thing you have to do is to save the life and come up with a definitive diagnosis later. So if they're hemorrhaging to death, is there a way you can stop the bleeding? You don't need to know exactly what's bleeding right now, just stop the bleeding. So direct pressure, tourniquet, whatever you have to do. If they're not breathing, get them an airway, find an airway, whether you have to trach them, crike them, whether you can actually just put an ET tube in, whatever is killing them, take care of that first and we'll figure out why in a little bit later. Understanding there's a physiologic approach to this, which we'll talk about in great detail. Time is of the essence, do no further harm. All of this is sort of commonsensical. So everything that has to do with trauma starts with the ABCs. Airway, breathing, and circulation. That's first and foremost all the time. I guarantee you that'll show up on your test somewhere. Airway, breathing, circulation, the ABCs of trauma. So again, when you're talking about airway, can the patient talk to you? Do you hear stridor when they're talking? Can they talk to you in complete sentences, or are they out of breath? Are they gurgling blood and spraying blood or vomit everywhere when they're trying to talk to you? These are the things. Do they have a patent airway that they can communicate with? While you're assessing this, you need to make sure you maintain inline stabilization of their C-spine. Breathing. So they may have an airway, but they may have a horrible flail chest or crushed chest and unable to breathe. So do you see their chest while moving? Is it moving symmetrically? Are they taking big enough breaths that they can sustain life with that? Or are they guppy breathing and gasping? Circulation, this is going to be distal pulses, looking at their blood pressure, seeing if they're actively hemorrhaging. Disability is assessing their neurologic status. So are they awake enough to protect their airway? You know, we'll get into it a little more later, but we always say GCS of 8, intubate. So 8 or lower, they automatically get an intubation. I'll tell you that we always say ABCs first, with D being disability coming last, but I'll guarantee you that D, the GCS, is it's one of the things that I assess the minute they roll in the door, because that's also, gosh darn it. That's one of the things that I feel like I keep doing something. That's going to help me determine their airway. Like, is it patent? Are they going to be able to protect it and maintain it? And then exposure. So every trauma patient gets naked. We do that to them. It's lovely. There are a lot of places, even on a thin person, that you can hide injuries. Armpits, groin, scrotum. That sucker hides a lot of stuff. So you have to get the patient completely naked and fully assess them. I usually tell people, if you have an orifice, I have a tube or a finger for it. So be prepared. Always make sure you wear your good undies when you go out and do dumb things. The team sequence, so you're going to start with your primary survey. So your ABCs and any immediate adjuncts, whether that's the FAST exam, which is the focused ultrasound exam, whether that's a chest x-ray or pelvic x-ray, ABIs, or any of the things that have to happen immediately in the assessment. And then once you get through all of that, then you can start going to CT scans and doing that, and then doing a detailed secondary survey, which is when we start looking at them from head to toe. This whole lecture is set up for someone who is working in the community and they don't have all of the resources to provide full and total care for the patient. So you'll see a lot of stuff of me talking about safe transfer and definitive care. I will tell you we are the safe or the definitive care for everybody else. I don't transfer people out. So this is sort of set up if you work out in a community practice or something like that, what you need to know, what you need to do, what you need to be prepared to tell me about when you're calling me to transfer the patient to me. So a lot of this happens all completely simultaneously. When a patient rolls into the shock room, the way it's set up is if they activate a code 77 or a trauma 1, which is the highest level trauma activation you can activate, the ER attending and resident is there, the respiratory therapist is there. Oftentimes, daytime trauma, there's a pharmacist there, nighttime trauma, not so much. You have 2 nurses, and then you have a third nurse that's actually the charter. One nurse is getting blood work and setting up the rapid infuser if we need it. One person is getting the patient on the monitor and getting vitals for me. And then my team consists of a chief, a mid-level, and an intern. The intern's standing in some corner hoping to high hell that nobody calls on them to do anything because they're scared, and they're charting and doing all the documentation. The mid-level is the one that runs the trauma, so they're up at the patient's bedside. They're usually on the patient's right side. They're listening and doing the initial exam. And then the chief resident stands at the foot of the bed. Chief resident basically is feeling for pedal pulses. If you have pedal pulses, your blood pressure is at least 75 to 80. You're not immediately dying, and that's sort of their role, is to guide the chief or the mid-level. I typically stand in the doorway and heckle for the most part. What I do is watch the patient when they roll in, because I can usually tell just by looking at them whether they're sick or not sick, just when they will roll by me in the door. There's a lot of different things, including patient's color, diaphoretic, whether they're still, whether they're laying about. We have what we call the cell phone sign, where they come in texting already or calling people. That usually means they're not going to die immediately. If I actually put a gown on and step up to the table, I'm either irritated by the way the case is going or I'm worried. So there's a lot of people doing a lot, mother of God, doing a lot of things at the same time. So the paramedics, they go out, they get the call, they go see the patient, and their role is to transport the patient to the closest appropriate facility. So technically, they can bypass one of the community hospitals to get to a level 1 trauma center if it's the safest. If the patient is actively arresting and doing those things, they may stop at the closest hospital just to get them to the hospital. But they cannot, in theory, bypass one level 1 to get to another. So they should never drive right by Methodist to get to us. But there are certain things that come into play, like patient request versus Methodist could be on diversion or we could be on diversion, and so you have to bypass one to get to the other. They have lots of different transport guidelines and protocols that I really don't pay any attention to. I just take care of the patient when they show up. They have online medical directions, so they can call into the hospital and say, this patient's crazy, can I give them some Versed, can I give them some Ativan, or this patient doesn't want to come to the hospital, are you okay with me turning them loose? They can get information and discuss with us if they need help. But them calling in allows us to mobilize our resources. So when they call in and they give a list of information, I don't even think I have one on my pager right now, I deleted them all. The page that I get will say, code 77, 36-year-old male, gunshot wound to head, GCS of 3, agonal respirations, unable to obtain blood pressure. Or I'll get something, and that usually sort of starts prepping me for what I'm going to be prepared for. But once that comes across, everything mobilizes, and the RT, the pharmacist, the ER people, we're all there at the same time, usually before the patient ever gets there, and we're ready to go. That page is really important to me because I start giving my team some direction. If it's a gunshot wound to the chest and loss of pulses, I start talking to my team. If we cut the chest, your role is to put the chest tube in. Your role is to be on the left side. You're going to cut the chest. You're going to get the finishetto in. And so I can start giving them guidelines so we're ready for a smooth transition into care when they get here. So this is sort of what we all just talked about. Transfer agreements are something that all level 1 trauma centers have, and even level 2 and 3 trauma centers have. So Community Hospital has a transfer agreement with Eskenazi that we will take any and all trauma that they want to transfer to us, whether it's because the patient wants it or whether it's because they're just uncomfortable handling it. We will take and accept any trauma. But the things more important to that are transfer agreements that the level 1s have set up between each other for specific patient care. Eskenazi does not have a cardiopulmonary bypass pump, so I cannot do any pump cases. Yes, I can fix a gunshot wound to the heart or a stab wound to the heart, but if I have to put the patient on pump, I can't handle that. So aortic injuries that are semi-stable, we have a transfer agreement with Methodist because they do all the cardiopulmonary bypass. We will transfer to them. Methodist is incapable of managing burn patients, so we have a transfer agreement that they can send any and all burn patients to us, and they'll be cared for in our unit. That is how you can get certified as a level 1 center. We can provide everything because we have this agreement in place, and it's never really been a problem. And then a QI program is important. It's a quality improvement program. We're never satisfied. Obviously, we think we're the best, but we're never satisfied by that. Every death that we have or every complication, every week on Tuesday, we have specific trauma M&M where we talk about every single complication that happened on the service, whether it's a wound infection, whether it's the patient died, whether it was a missed injury, whatever it is, we talk about it every single Tuesday. But we also have a program where every single trauma death gets reviewed. So if the patient was my patient when they came in and they died, 2 of my partners will review it and decide if they thought things should have been done differently, or if it was came in dead, stayed dead, nothing to do. And we assess that, and then we go over it. And if there's a problem that we identify, let's say the radiologist took 3 hours to get a read that was bad back to us, then we can take it back to radiology, sit down with their people, and go over it. So we're always improving the program. We're never happy. We're trying not to be stagnant. We're trying to get better all the time. I'm pretty sure you guys know what standard precautions are. I'll tell you to do it. I don't always do it. I regret it a lot. I've thrown away a lot of clothes because I didn't do it, and I've had a lot of gross stuff on me because I didn't do it. So when you walk into the trauma room, always put your clothes on. Don't go in naked anyway, but certainly put a gown and gloves and trauma boots and all those things on. There's nothing more disgusting than walking around in your shoes and feeling blood up between your toes because you didn't have your trauma boots on. So triaging patients. When we get mass casualty events or you get multiple patients at once, especially after 5, 6 p.m., there's only one of us in the building as an attending, so I have to decide what I'm going to do first. I certainly have a backup system. I can call one of my partners in, but most of us live about a half an hour away at this point, so you got to be able to figure it out for 30 to 40 minutes till someone can get in here. ABCs. So the sickest patient first gets treated. There's also determination of salvageability, which is a hard thing to do. To decide that someone isn't worth saving or is not savable is tough to do. It feels a little bit like you're playing God. But in a way, we sort of do it every day when we decide who we will and won't operate on and why, and the discussions that we have in the family. But these urgent ones, when you look at the patient and you're like, they have a gunshot wound to the head and their brain is exploding out of this side, and this patient has a gunshot wound to the belly with unstable vitals. This guy, probably not going to do well if it went in here and came out here. This guy has a potential chance. So I'm going to take my chances with the gunshot wound to the belly and do what I can and leave an intern or someone who can hang out with the other gunshot wound to the head till someone else can get in and help me manage it. Again, it's not fun. It's not good. It never feels good. But it's something you have to do. So primary survey. The priorities are the same for every single patient. It doesn't matter if they're old, if they're young, if they're pregnant, if they're just the average Joe. Everybody starts with ABCs. So things to think about with the various age groups. So kids, trauma is the leading cause of death. So a lot of this is what we call non-accidental trauma, meaning abuse. So you'll see a lot of head bleeds and intracranial problems from non-accidental traumas, from rolling off the changing table, from burns in the bathtub, a lot of different things. And babies are not tiny adults. Children are not tiny adults. Understanding that their vital signs are different and what normal is for a baby's vital is very important. A heart rate of 160 might be normal for an infant, right? So freaking out or getting worked up about that is not going to do you any good. Understanding that they have a very aggressive physiologic response. They have the ability to compensate really, really well because they're young and healthy in most instances. The problem is they actually have limited reserve because they're compensating so well that by the time you identify that they have a problem, they've maxed out their compensatory ability and they fall off the cliff. So you have to have a high index of suspicion that something's going on. Understanding that if you have to intubate them, their airway is different. They have a very short anterior trachea. Having the right equipment to do that. Dosing your medications is very different in a baby. When I used to have to work at Riley, it was awful, and the nurses would call me with a problem, and I would say, are they human-sized or not? You know, because once they get to a certain, about the 13, 14-year-old, you dose them just like you would an adult. It's all weight-based. But these young babies, figuring out the dosage is just terrible. Quick and dirty way is to have a Breslow tape available, and it literally you just lay it out beside the child, and it helps you dose things based on where they fall on the Breslow tape. Understanding that their bones are not as hard as ours yet. They're still very pliable, so doing things like putting chest tubes in a baby is much more difficult because the whole chest wall will cave in on you. Understanding that if a baby has rib fractures, the force that they had to sustain to break those ribs is huge, meaning there's a lot of important stuff between that rib cage, right? So they have a high risk of having liver and spleen injuries, high risk of having blunt cardiac injury, esophageal tears, aortic injuries, holy shit, from all of this stuff. Adults, our chest walls are hard, so they break, and you may have a pulmonary contusion or even a small pulmonary laceration, but it is what it is. Most of the time, you don't have to do anything about it. We talked about that. Holy guacamole. Getting an IV in a baby is also kind of comical. It's like trying to put an IV in a marshmallow. So they're so chubby and those vessels are so teeny tiny that actually on the rare occasion that I have to do it because someone brought me a baby, we usually go with IOs on them. They work reasonably well, and as long as you have the right equipment, then it's easier than trying to get an IV in those little puff balls. Sort of the same. Special considerations in pregnancy. What do you guys worry about in pregnancy? I'm bored now. Huh? Why? Right. Right. So all these like sweet shows you see on TV where someone's cutting baby out of mom and all this stuff, the vast majority of the time that's garbage. Okay? The mom's body, yes, it feeds the baby, yes, it takes care of the baby, but mom's body is designed for mom to survive. Okay? So if something happens and mom is losing her blood, mom does not have oxygen, mom's body is going to shut down blood supply to the baby. It's going to clamp everything down to try to supply mom's heart, kidneys, lungs, brain. So more often than not, if mom is dead, baby's already dead. Okay? Rarely, if something happens quick, like mom dies from a C-spine fracture where they sort of atlanto-occipital dislocation or something like that, sure, the baby probably has 5 to 7 minutes where it's still viable. But in most instances, if the mom has been in a car wreck, has sustained some trauma, mom's body has already sort of shut everything down to the baby to take care of mom. So baby is most likely gone. So always remember that to save baby, you have to save mom. There's some big story that everyone likes to talk about, the heroics of some baby they cut out of mom recently, and the baby made it for 2 days. The baby made it for 2 days. Okay, the baby didn't make it. Mom showed up with her belly hanging wide open because someone cut her out, but had no idea how to close it, how to put it back together, how to do anything for it. The uterus bleeds a lot. So if mom had any chance of survival, now her uterus is hanging open, hemorrhaging everywhere, and it wasn't going to happen. So just remember that mom is number one priority. To save baby, you have to save mom. You also need to remember that the physiology or mom's physiology is a little different than the average woman. There's certain things that can happen. What can happen? Let's say someone is 6 months pregnant and you put them on your cart, get them into the ambulance, and all of a sudden their blood pressure is really low. Mom tells you she feels lightheaded, she feels like she's going to barf. What happened? Yeah, why is that a problem? Yeah, so you've decreased her venous return. She has no venous return, right? So always bump them up. Again, remember you have to maintain inline stabilization, so don't just crank them up and stick something under their back. You have to log roll them to the side, put something on there that's going to be the length of their body to keep them up with their spine in line, right? blood pressure of a pregnant person tends to be slightly lower, heart rate can be a little bit higher, so understanding that their physiology is a little different is important. I usually say that pregnant ladies are my least favorite trauma patients. They're nerve-wracking and everyone's sphincters are tight. And there's a lot of discussion that happens when we know, because I can assure you that they call in right away and say, a patient's 38 weeks pregnant, blah, blah, blah. So when we know that up front, we have OB down there, we have peds down there, we have incubator in the room, but I literally sound like a raging bitch most of the time, but I literally will talk to the OB up front and say, you stay out until I assess the patient, I do my primary survey, and then you can come in. We will call you when we need you. And a lot of times if I'm already doing CPR or something like that, I'll let them roll in and slap the ultrasound on there to see if baby has any fetal heart tones. If baby has any fetal heart tones, we'll let them take the baby then and there. But I would say never have they had fetal heart tones if I'm already doing CPR on mom. So the other thing is that pregnant ladies are at high risk for aspiration because they usually have big distended stomachs. Their stomachs don't empty, in part because the baby's squishing it, but in part because of the hormonal regulation. Their stomachs are just a little different, which is why a lot of these patients have reflux and things like that. So another thing to be careful of, letting them get lightheaded, letting them lay flat. They're at pretty significant risk for vomiting. And then you have to remember isoimmunizations. You need to give the patient RhoGAM, things like that. Old people. Now, trauma becomes the 5th leading cause of death in the elderly population. We define elderly, which my parents would punch me right in the face if I said this, but we define elderly as 65 and older. We actually have protocols now with how unhealthy our population is currently, that patients 55 and older are actually started to be treated as early elderly. So when we have something called the ACE team, which is the geriatric team, and then we have our protocols are if the patient is 55 or older as a trauma patient, they get a medicine consult for any comorbidities they may have. And then if they're 65 or older, they get both medicine and ACE. So a couple of my partners are approaching that, so I really love enjoying telling them that hip fractures are lethal injuries in them and that they have a nursing home in their future and things like that. So, but elderly trauma, it can be catastrophic. So this ended up falling behind cancers and heart disease and all of those other things, but trauma is still a pretty big deal. Just like there's non-accidental trauma with babies, there's not an accidental trauma with elderly people, okay? These people, especially the Alzheimer's, the dementia patients, they can be frustrating to talk to because some of them are mean, some of them are aggressive. It's frustrating to repeat yourself over and over, and they're in facilities and they ultimately end up getting pushed, shoved, abused, beat up, anything like that. So just like if you see a weird skeletal pattern on an x-ray of a baby, if you see it on an adult, you have to have a high index of suspicion of elder abuse. It's awful. It makes me angry. People that beat up people like our age, fine, whatever. People who beat up babies, pets, or old people should just die in my world. So for the opposite reason that babies need early and aggressive care and a high index of suspicion, the elderly need the same thing, okay? Not because they've already compensated to allow for the trauma, but these people just to live are already exceeding or maximizing their compensatory efforts, right? So they have COPD and they have heart disease and their blood vessels don't work very well. So everything they do on a daily basis to survive is already sort of using up their reserve. And so if you bag that reserve or you tag anything else, they just can't sustain it. You also have to remember that these patients are oftentimes on many, many medications. So their blood pressure may be 80, but their heart rate is 70. And you're like, that doesn't make any sense. They got a beta blocker. That's the big one that we miss all the time. So you can't just go based on that. That's why knowing their meds, knowing their history is important. The other very important one is a lot of them have cerebral shrinkage, so any small jostling can cause head bleeds and problems like that. So are they on any blood thinners? Aspirin, Plavix, Coumadin, any of the new ones that we can't reverse and we love so much. But again, the same thing. Always starts with airway. So assessing the patency. Are they snoring? Are they stridorous? Are they gurgling? Whether it's vomit, saliva, or blood. Rocking chest wall motions if they don't have symmetrical expansion of the chest, or they have bad maxillofacial trauma. There's some patients that are sitting up. We get a lot of gunshots to the face. It's awful. It's really gross too. but they're sitting up and they're leaning over and there's blood just pouring out of their mouth, right? And though they're maintaining their airway while they're sitting up with the suction catheter, for us to lay them back, examine them, to do anything for them, they start choking, aspirating, and sitting back up. Those kinds of patients are the patients that you want to intubate electively before you're in a hurry and trying to do that, because it's not going to be an easy intubation. This is going to be an awake intubation. Otherwise, you'll end up, you paralyze them and they can't protect that airway anymore. All of that stuff's going to go down their lungs. They're going to aspirate all this blood and snot and everything else, and it's going to cause bad problems. So you have to have a high index of suspicion and a low threshold to intubate. So remember, when you're looking at their airway, chin lift, jaw thrust, you can't just crank their head back. Most of these guys are in a C-collar or should be in a C-collar. So this is all literally just grabbing the angle of the mandible and pulling it forward. Sometimes, if they're pretty gorked and they're not going to bite you, I've been bit before, it's not fun, don't do that. I literally will just fish hook them. I'll stick my finger in their mouth and grab their jaw and just pull it forward until I can get a nasopharyngeal airway in, or an oropharyngeal airway, which I try not to do in the shock room very much because they all aspirate. They'll vomit, you activate their gag reflex, and be cautious with that. Look, listen, and feel. Listening is tough in the shock room. It's very loud, but we do try to do it. Looking is important. Feeling, you're feeling for crepitus. You can actually just put your hand on there and feel how the chest wall motion is. But most of the time, if they're thin enough, you can see if their chest wall is moving symmetrically or not. Definitive airway, and reassess frequently. The reassessing part is something that you have to keep thinking about, is that just because the first time you looked at them and it looked okay, doesn't mean it's going to stay okay. So you assess their airway and they were talking to you, but a little suspect, maybe speaking in 2 or 3 word sentences, said they feel a little short of breath. You listened to them, they had good bilateral breath sounds. You went on and started dealing with the hemorrhage from their leg. You're trying to take the tourniquet down and take a look at it, and all of a sudden you ask the patient a question and you realize they're not answering you anymore. You got to start all over. You don't get to keep going down and looking at the leg. You have to start all the way back over, reassessing airway and breathing and seeing if you need to tube them. So you're never done. It keeps going back over and over and over. This is sort of the stuff that we talked about. Breathing. Standard teaching used to say that we put supplemental oxygen on everybody. We don't do that anymore, but if their oxygen saturation is low, if we're suspicious of anything, if we think they have a pneumo, they'll get supplemental oxygen. Ventilating is needed. So tension pneumothorax, how do I identify that in a shock room? Chest x-ray? That was a lot of gibberish. What? You were talking. Okay, so how do I see mediastinal deviation? Ooh, a chest x-ray identifying tension pneumothorax is a missed injury. We have x-rays, but we shouldn't. You're right, but what are you going to see deviated? Tracheal deviation, correct, away from the site of injury. Again, recall that a lot of these patients have a C-collar on, so that's not super obvious. They do have a hole right here, but it's not super obvious. You may actually have to put them in inline stabilization, take a look. What else? Altered breath sounds or decreased breath sounds, yep. Potentially, yeah. Yes.
Recently, you can also do with ultrasound.
You can. And we have, but I will tell you that if they have a tension pneumo, you should know it before you bust out an ultrasound. Because 99% of the time it's in the room because we do a fast on every patient, but it takes a minute to get it turned on and to let it fire up. So if they have sudden cardiovascular collapse, if their blood pressure's dropping, their heart rate's going up, you have decreased breath sounds, you have tracheal deviation, you have a bunch of crepitus, anything like that, you should just put the tube in, right? So how do you treat it? Don't look at that. Needle decompression is what you would do in the field. If you're in the shock room, how are you going to treat it? Chest tube. I can put a chest tube in just as fast as I can jab a needle into someone's chest. Everything's sitting right there. So tell me where you needle decompress somebody. Yeah, they're teaching some people to do it over here. That's still not standard teaching. Standard teaching is midclavicular line, second intercostal space. And so remember that you're doing this for a patient who you think has a pneumothorax, right? So don't be gentle when you're ramming a needle in there. I will tell you that a solid 80% of the ones that roll in from the field and they say we needle decompress them, the needle isn't, or the angiocath is not in the chest anymore. Okay? Ladies with big boobs, not my problem, but ladies with big boobs, those things flop up here and it's a lot of tissue you got to get through in a short angiocath. So you want to hork the boob down before you do it. Gentlemen with large pecs are also difficult to get through. So you can pop in, you can decompress a little bit, and then as soon as you let go of it, it will back out and you've lost it. So if you're going to do it, either keep a hand on it and keep it in there. Make sure you get it in is the big thing, right? You think the lung's down, so who cares? You're not going to jab the lung, stick the needle in and get it. You want to do it with a big needle. What size needle is a big needle?
16.
That's a really big one. So I will say the ambulances have 16s and 14s, and that's great if you can get it. In the shock rooms and most of the rooms in the hospital, they don't have that, so an 18 gauge is what you'll use, but the biggest one you can get your hands on is what you want to use. Okay, as soon as you get there and I see someone's needle decompressed, I'm going to put a chest tube in them anyway, so it is what it is. Don't be gentle with it. Open pneumothorax. Why do I want to put an occlusive dressing on an open pneumothorax? It's a sucking wound. Tell me how I put that dressing on. Why not all 4 sides?
You want air out without bringing in.
What happens if I do tape it on all 4 sides? Yeah, yeah. Okay, and then remember to reassess frequently. Circulation, again, is a little different for all of these various reasons. So reasons for non-hemorrhagic shock is going to be cardiac tamponade, which we will identify on ultrasound, because all that cute stuff when you say, oh, they had muffled heart sounds, that's probably lovely on the floor or somewhere else, but in a shock room when 30,000 people are yelling, you're not going to hear muffled heart sounds. You barely hear heart sounds at all. Tension pneumothorax certainly can cause non-hemorrhagic shock, neurogenic shock, and septic shock. So our spinal cord injury patients can have neurogenic shock. Septic shock, unless you're getting one of these patients from a nursing home who fell out of bed because they were septic and now they're called a trauma patient, you're probably not going to see that in the shock room. That's going to be something that happens up later on the floor and stuff like that. So these patients in the initial assessment, cardiac tamponade is always a suspicion. Hemorrhagic shock is going to be your number 1 suspicion anytime you have trauma. But then you have to start thinking about, did they hit their chest on the steering wheel? Are they old and frail and an airbag drilled them in the chest? Did they have a gunshot wound in the chest? Any of that stuff. Neurogenic shock, the treatment of neurogenic shock is not pressors initially. Everyone's like, oh, I need to know whether it's hemorrhagic or neurogenic because I'm going to give them pressors if it's neurogenic. It's not the answer, right? Why do people have neurogenic shock? What happens to the body? You've lost your sympathetic tone, right? So all your blood vessels dilated. You have no venous return coming back to the heart. So first thing you should do is just fill the tank. Just like you would for hemorrhagic shock, is fill the tank. If you just put more in, oftentimes it will start getting you some cardiac output and some cardiac return. So initial treatment is the same for cardiogenic, for neurogenic, and for hemorrhagic shock. So in the shock room, your first response is to give blood or fluid right up front. Don't be starting pressors or you really will hear me swear. Oh, I got excited. I thought you had a question. Turns out you had an itch. So circulation, assessing organ perfusion is going to be important, right? So skin color is hugely important. It doesn't matter if you're pasty white like me or if you are black. You will have altered skin color. You can see it on their tongue. You can see it on their feet. If they don't look right, then be concerned. Pulse rate and character, is it regular? Is it fast? Is it slow? Slow heart rate doesn't necessarily just mean that the patient is on a beta blocker or something like that. The other thing that you got to worry about a lot is that they have a bad brain injury and they're actually trying to herniate. So understanding what's happening there and how it's changing is important. Assessing organ perfusion. So these patients in the trauma setting typically vasoconstrict, right? Because they're trying to save their own lives, so they vasoconstrict, they clamp everything down, and the primary blood supply goes to the kidneys, the brain, and the heart. You're trying to spare that. The kidneys are the most finicky organ in the body. They're even more finicky than the brain, and that's usually where we see that a patient has a big problem, but it doesn't happen on the initial assessment. I'll see this when I get up in the ICU and they suddenly have an AKI because they took a small blood pressure hit while they were in the ER for a little bit. Questions about any of that? That's all kind of common sense. The clacking has slowed down, so I think you are mostly caught up.
When are you going to actually initiate some basic assessments then? If you're giving them the feeling that-
Almost never in trauma, or are you talking for neurogenic?
Yeah.
Neurogenic. So if I've given them a couple liters of blood, I've gotten them through the CT scanner and know that they're not hemorrhaging somewhere and all I have is a bad like C-spine or T-spine fracture and have no other indication, then I'll think about pressors at that point. But I typically don't do pressors until I have proven that it's not bleeding. Because if you take them and you put them on pressors, which clamps everything down, including their splanchnic circulation, now I've compromised their intestine and everything else. I don't want to do that. I'd rather just keep flooding the tank. And especially if you remember, trauma is primarily a disease of the young, they can usually take a lot of fluid. So they can handle it, just keep blasting them. Yes?
I feel like we didn't really learn neurogenic shock as well.
Uh-huh.
So like how long does it last and is it like based on excluding all other shocks to get through?
It's a diagnosis of exclusion, so you have to make sure that your heart's pumping, that you have blood, you're not bleeding. And again, septic shock is not usually going to be the cause of urgent or emergent shock. That comes sort of later down the road. So if you know that they have a bad spinal cord injury, your index of suspicion needs to be pretty high. But again, a lot of times you can get them through just by keeping the tank full. If you get to the point where you need pressors, this can last weeks to months. But there's other things you can do in terms of if they're otherwise ready to go home, but they're hanging out on a dopamine drip because either if it's a high C-spine, they can't moderate their heart rate. Lower thoracic and lumbar spine typically just means everything dilated. And so usually you can fill the tank and do okay with them. The C-spine guys end up being on dopamine drips forever. A lot of times, as long as it's not a heart rate issue, I can put them on an oral medication called Midodrine, which will help clamp them down, and then they can actually go out and live their life on Midodrine. Yay? Yay. All right, so bleeding. Most important thing about bleeding is direct pressure or finding a way to stop the bleeding, right? Typically, I like to tell people, has anyone taken Stop the Bleed? Any of you guys taken that course? Yeah. Okay, so I like that course, but it's sort of the bane of my existence because that course tells you to slap gauze ABD pads on, things like that, and just put pressure on stuff. That's fine and dandy, but what you want to do is the smallest point of direct contact that you can get. So if that's 2 fingers, that's going to be better. Anything you can do that you're not just slapping these. So we have people come in all the time and everyone's just holding like big ABD pads all over them and they're bleeding out all over the floor and things like that and they're just holding these ABD pads on. And you move their hand away and you look at the wound and you put 2 fingers. And yes, I might submerge my finger in someone's abdomen this far and yes, they're going to yell out in pain and yes, it hurts, but the bleeding will stop, okay? If you're just slapping something big on them and doing this, it's like trying to stop, it's just going to leak all the way around it, all right? The smallest point of contact you can get is the best choice, okay? I also, in the leg and in the arm is all fine. That course teaches you to just shove gauze and shit in there. Doing that in the belly is not a great option. I prefer you not shove gauze blindly into an abdomen. So direct pressure is number 1. Tourniquets are very important and good. We used to never see them, and now we oversee them, but I'd almost rather oversee them than not see them because I certainly think they're saving lives. I will also tell you that a solid 50+% of the time, the tourniquet isn't on tight enough because I can still feel a pulse distal to it. The patients will yell. It hurts like hell when you put the tourniquet on. It hurts like hell when it's on and you have actually slowed or stopped the blood flow. They'll start yelling that they can't feel their arm's burning, their arm's tingling, they're miserable, and people want to have a heart and like loosen it up. Well, that doesn't actually help. It's awful. I'm sorry, it hurts. So direct pressure, tourniquets, don't tourniquet someone's neck, don't tourniquet someone's abdomen. It's for the extremities. Getting them to the operating room is going to be the best option for them. And then always avoid blind clamping, right? So even if you see the vessel, try not to just fire clamps on it because it chews up and tears up unless you truly have vascular clamps, the ends of the vessels, and makes the repair even more difficult. Then we're cutting back even further to get a clean repair and put some sort of graft in them, whether it's a vein graft or a synthetic graft. So no blind and clamping, lots of pressure, lots of tourniquets. Questions? Yes.
I mean, maybe they've had a couple of iterations of Stop the Bleed.
Mhm.
They've done a much better job. They don't teach the wound pack abdomen, the wound pack junction wounds. So it's not as haphazard. We're going to have more people stop the bleed.
I agree, I want you to stop the bleed. I just don't like blind packing of wounds unless it's in the leg or an arm
Yeah,
or
yeah,
something like
yeah,
that. That's
sure.
all fine. A butt cheek is fine. Butts can bleed a lot. Butts are gross for various reasons. So yeah, I've seen every iteration of it. I was part of the whole bringing it to Indy program. It's just, we'll just smile and nod about that. All right, so circulation. Big thing is to obtain IV access best you can. If you cannot get venous access, if you work at the county hospital, a lot of people have done a lot of things to their veins and it's very difficult to get venous access. What do? IO, where? Hold shoulder, like what, you want me to slap it in the deltoid? What is that? Well, what are you putting it in? Humeral IO, yep. So humeral or tibial are fine. Humeral is actually, they've done some studies that a humeral IO is almost equivalent to a central line. It gets to the right heart about as quick as a central line does. But if you can get good 16 or 18 gauge peripherals in the arms, just as good. Just as good, I'll take it any day of the week. If you've got good 16 or 18 gauge peripherals, I will take that over a central line, okay? Because most of the time if I tell someone to put a central line in, they give me a triple lumen, and that's useless, okay? That's wonderful if you want to give someone TPN, if you want to put them on pressors, if you want to do any of that stuff. A triple lumen central line is absolutely useless in the shock room for resuscitation. Does anybody have any idea why? Because it's a long, yeah,
Not wide for it after the volume of fluid being pressed through.
yeah. Exactly. It is a long, very skinny tube, and I can actually bolus faster through a 18 gauge peripheral than I can through that. If you are going to put central access, you want to put in something called a trauma introducer. It's got a lot of names, a cordis, a sheath. It's got a ton of names, but it's something that's short and it's fat. It's about the size of my pinky. You want to put that in if you're actually going for central access. Where's the best place to get central access? Okay, what are the 3 places I can get central access? Subclavian, femoral, and IJ. Okay, so how do I decide where I'm going to put it? Huh? Depending on the trauma. That's a non-committal answer. Who's the politician in here? Subclavian. That's typically a surgeon's preference is going to be the subclavian. I'll tell you the sheaths in a subclavian tend to not be awesome because they kink off really easy and it's not great. Plus, everybody in the sun is up here messing around and the subclavian is hard to get to. Now, if you've already put a chest tube in them, a subclavian is great because the number1 risk of a subclavian central line is dropping the lung. Chest tube is already there, you're protected, you blame the trauma. It's not your fault. Femoral is what we ultimately do a lot of times in the shock room simply because the groin is something you can get to. Now, if they're shot in the belly right here and you stick a groin line right here, solid chance they've tagged the IVC or something bad and everything you put in there is just going to float around in the belly. So there has to be some sort of common sense as to where the injury is, as to where you're going to put your line in. IJ oftentimes doesn't happen in the shock room simply because a lot of people have C-collars on and you don't want to take the collar off to put a line. So the most common places are going to be subclavian and femoral with some thought process as to where the injury is. If you can get above the injury, that's good. If you're below the injury, you have to be like, eh. So if the injury's over here on this side, I'll probably put it in on the opposite side just in hopes that maybe it'll get there. But central access, any sort of access is important. So giving crystalloid was old ATLS teaching. Old ATLS teaching said everybody got 2 liters of crystalloid. If they're still hypotensive or responding to fluids and need more fluids, then they get blood. New teaching, and they're actually sort of taking it out of ATLS, is if the reason they're hypotensive is because they hemorrhage, just give them blood, right? So that's why the paramedic report is incredibly important to us. We like to know a lot. Number 1, they can tell you a lot about the mechanism typically. Number 2, they can tell you if there's a massive blood loss at the scene. And number three, oftentimes they've spoken to someone or the patient and know some of their history or some of what's going on, and they can give you some of those details. So if they tell you that patient comes in and they're not really bleeding for you, but they're pale and they're diaphoretic and they're swirling around in the bed, but they tell you that there is at least 2 liters of blood loss at the scene, just start the blood. Don't be playing around with crystal. You're just going to make them more acidotic, right? You're going to thin out the blood, you're going to make them cold, and you're going to make them more acidotic, so just get them going. These are sort of the classes of shock, 1, 2, 3, and 4. They like to test on these a lot. And the biggest things to remember is that class 1 shock, everything is kind of normal, okay? You know they had some blood loss, but oftentimes their heart rate is still less than 100, their blood pressure is normal, their mentation is usually pretty normal, occasionally slightly anxious. The biggest thing that you start getting worried about is when they become lethargic, okay? So lethargic means they're in class 4 shock, and that's a bad problem. So by the time you get to class 3, you're tachycardic and you're usually hypotensive, and you start to get a little squirrely. Those patients actually kind of get on your nerves a little bit because you're trying to take care of them, you're trying to do something, and they're pushing you off of them, and they're doing stuff that's a little bit obnoxious. They usually get a little tachypnic at that point, but at the point where they're lethargic, so trauma patients who are pale, diaphoretic, and still scare the hell out of me, okay? That means bad stuff's happening and we're probably going to be operating shortly. Trauma patients who are shouting, yelling, kind of squirrely, I might be operating on them, but my threshold for what class of shock is, they're a little bit lower, so somewhere in the 2 to 3 range usually. And we talked about tension pneumothoraces. Massive hemothorax is going to be all about volume resuscitation and draining it. And cardiac tamponade. So I will tell you that I have never ever done a pericardiocentesis in the shock room. I've done it in the ICU, but I've never done it in the shock room. The FAST exam has essentially eliminated the need for that. So you put an ultrasound on their heart and they have a bunch of fluid on their heart, you're going to the operating room. What am I going to do in the operating room? Mumbles don't work either. Shout something. Okay, so sternotomy. So sternotomy and repair, probably. I'm probably not going to get to the heart in the operating room via a thoracotomy just because I got to shove the lung out of the way and get in there and work. So if I'm taking them to the OR because I see a bunch of fluid around the heart, I'm going to do a sternotomy and take a look. What's the other option? I'm not going to lie, I've done a sternotomy on someone and they had a sympathetic effusion and I felt like a horse's ass. So, what? Yeah, so I can do a pericardial window, make a small incision right down by the xiphoid, actually remove the xiphoid, open up the pericardium from there. You don't actually get into the abdominal cavity, open up the pericardium. If what you get back is blood, then it's sternotomy and go. If what you get back is serous fluid, you can tuck a little drain up there, close, and be done, and you've spared them a sternotomy. Which I will tell you, they actually recover from a sternotomy significantly better than they recover from a thoracotomy. So if you can spare them either of those, though, it's ideal. But yeah, if I'm concerned about tamponade or I'm concerned about fluid on the heart, because you have to assume that all fluid on the heart in a trauma is blood. But if the patient is acting completely hemodynamically stable, it's not true tamponade, but they have a bunch of fluid there that you're like, then I will usually start with the pericardial window. If they are unstable, they are not acting right, when I put the ultrasound on them, their heart is truly having tamponade issues, we're just going to go straight to the sternotomy. I'm not going to waste time. I'd rather be wrong and then give them a sternotomy than be sad that I missed it and killed them. All right, so baseline neurologic evaluation, assessing the GCS and pupillary response. Again, always observe for neurologic deterioration. Substance abuse, drugs, alcohol can all manifest itself as what looks like a neurologic injury. But on the flip side, there is a lot of implicit bias that we don't mean to have when the patient comes in drunk or when the patient has a known history of substance abuse or when the patient tells you they did something. We blame everything on the fact that they did that and sort of have this bias that, oh, it's just because they're drunk, it's just because, and we've had true missed injuries and bad problem diagnoses from that. So having a low index of suspicion to rescan their head if you're concerned that the clinical exam has changed right? Because as they sit there, they shouldn't be getting more intoxicated, right? They should be metabolizing stuff. So even if they were drunk when they came in, if the clinical exam changes or deteriorates, you probably need to re-image and relook. And then again, this is setting you up for neuroconsult and transfer if need be, but we don't transfer. All right, you guys know how to calculate the GCS, right? Have you studied all that? Okay, I don't need to do that. Remember that I lose all faith in you knowing even remotely what the heck you talk about if you come and tell me that someone's GCS is 2, okay? A table, the floor, has a GCS of 3. So the minute you start telling me stuff like patient's GCS was 0 or 1, everything you've said means nothing to me at this point. So best you can be is a 15, the worst you can be is a 3. A dead person has a 3. So GCS of 8, remember we intubate. Remember GCS of 8, we intubate. Do I need to say it a third time?
No.
Do you get the hint? Picking up what I'm putting down? All right, that's a boring one. So exposure. Remember to completely undress the patients. Especially with penetrating trauma, you can lose a lot of holes, wounds, injuries, and folds and crevices and places that you're not thinking about. So the axilla, the scrotum, like I said, the butt actually hides a lot of things. The pannus can hide. So you need to, you gotta warn people that you're gonna do that. So I usually say, buddy, we're gonna get in your groin real quick, looking for other injuries and things like that. The breast folds can hide a lot of injuries. And you need to look at everything. You need to log roll them. You need to look at their back. Even if I'm not going to do a rectal exam, I will spread their butt cheeks and look in their butt, not in the hole, but in the crack. If they have a helmet, most of the times the paramedics will remove the helmets for you. Some of the motorcycle helmets, they do not because they're very secure on there. So it's not a one-person job. It's a couple-man job to remove those helmets. But like I said, it's been a long time since I've removed them, partially because people don't wear them, but mostly because the paramedics will remove them for you. And then prevent hypothermia. So that's the first thing. We get them naked, we look around real quick, and then you'll hear someone shout for warm blankets. We have a blanket warmer right outside the shock room, and we'll come in and get them warm. Most of the time, these patients are already cool or cold, even in the summer. And then being cold actually makes you acidotic. It actually decreases your ability to clot your blood and perpetuates you towards the triangle of death. So keeping them warm is very important. Questions? This is all just sort of a review. I think we're going to start secondary survey in a second here. Questions about any of that? No? I'm going to go through secondary survey really quick because I want to get to the fun lecture and give you a minute to take a breath. Oh, good. I only did 10. We're not going to do secondary survey today. All right. Any questions about that? You guys need a break. Do it.
So I'm Kylie Mason's friend.
Oh, yeah.
So it's really nice to meet you.
It's nice to meet you. Carly, is that right?
Yes. I'll actually be rotating with you.
Okay.
When we start rotation. So,
It'll be fun. So is it in the summer? Will you be in the summer?
no. I am. Do you want to pause this real quick? Sorry to interrupt. Or is it a recording? I think I'm in December, actually. Yeah, that's the one.
So we're going to focus, I don't know why it keeps going straight to this page, focus on chest trauma specifically. So we'll talk a little bit about the difference between blunt and penetrating chest trauma. And like I said, I made this lecture for other people, so there are some weird, semi-inappropriate memes on it. Just ignore those and keep moving. So chest trauma accounts for about 10 to 15% of all trauma, with a 7% risk of serious thoracic injury. Again, these numbers are from several years ago, and they're probably even higher now. So about 1,500 patients present every day with life-threatening thoracic injuries. That's not the people that we're seeing for 1 or 2 rib fractures or for a clavicle fracture or for any of that. So approximately 1,500 people a day across the country have a life-threatening injury. These are associated with about 25% of deaths. And like I said, there are both blunt and penetrating mechanisms for pretty much everything, not just chest trauma. So remembering that there are oftentimes a lot of associated injury with chest trauma, especially those that are obtained via a blunt mechanism. So oftentimes, or most commonly, you're going to see extremity fractures too. So femur fractures, pelvic fractures, and association. Head injuries are the next most common thing to see in addition to a thoracic injury, but you can get a lot of abdominal injuries as well. So remember that the lower portion of the thoracic cavity houses the liver and the spleen, and even the stomach sits right there. So fracturing those ribs can actually cause bad penetrating injury to the solid organs of the abdominal cavity as well. And then spinal fractures are also related. So injuries that are specific to the chest, there's a lot of bony structures, including the ribs, the sternum, and the vertebrae. The spinal cord itself can be injured, the lungs, the trachea and bronchi, the heart, the great vessels, which would include the IVC and the aorta, the esophagus, the diaphragm, and then the soft tissues of the chest wall. The pec and the breast tissue can bleed a lot. You can actually lose a pretty large blood volume when you get into the pec muscle itself. So sometimes we get these sort of either penetrating from stab wounds that take this sharp angle from lateral towards medial of the pec, or gunshot wounds that can cause a lot of bleeding. The lateral thoracic artery sort of lays out there on the sidewall, and if that sucker gets dinged, it can bleed a lot, and it can bleed a lot into the breast. The breast can swell up. The breast, if it's not treated, can actually necrose the fatty tissue of the breast and can cause a bad breast injury requiring resection or mastectomy. So the soft tissue isn't something to just laugh at in the chest when they tell you that you did a CT and you have a blush or some sort of active extrav into the chest wall. That's a problem. The intercostal vessels can bleed a lot and can bleed a lot into the sub-Q, especially in overweight people who have a lot of excess sub-Q. The life-threatening injuries, there are several of these, but open pneumothorax or air embolus, which are two different things but can be related, is number one. So with an open pneumothorax, when someone goes to take a breath, you have a lot of negative intrathoracic pressure. It sucks the air into the chest wall, and then when you go to exhale, the air cannot escape, and so it causes the lung to get collapsed and pushed and pushed and pushed until the mediastinal structures are shoved over into the side away from injury. Okay, it will collapse the IVC, it will smush the heart, and it will also smush the lung on the opposite side, making breathing difficult from any aspect on either side. Tracheobronchial injuries. The importance of this slide is demonstrating that blunt injuries and penetrating trauma to the trachea happen in different spots. Blunt is most common at the carina, where penetrating is most common up in the neck where it's exposed. So this is a picture of, the one on the left is a picture of a tension pneumothorax. You can see the spine is in the middle and the heart is completely shifted over into the right chest such that the entire spine is exposed. So this here is the lung tissue. All this dark stuff here is pneumothorax. A lot of times the scapula itself here can be mistaken for lung markings or for the lung being up. You could misidentify the scapula, but note that the whole line of the lung is right here. Can you see that? Or is that blink? Is on there? Okay. So this is a demonstration of a tension pneumothorax. This x-ray on the right can mean a couple different things depending on the setting. So if this patient is up in the ICU and they've been there for a couple days and they're intubated and you see this, your first thought is, holy smokes, they mucus plugged, right? They mucus plugged the right side, the left side of their chest. This is a problem. We need to bronch them. If you see this x-ray in the shock room, this is blood until proven otherwise, right? Most of the time they're not mucus plugging in the shock room. That's something that happens a little later out in life. When you see this, this is blood until proven otherwise. What do I do with this? Good, tell me how you put a chest tube in. Someone volunteer to tell me. You can even pick a friend to help you tell me. Yes.
From what I used to, it's the fourth to fifth mid-axillary line, and then you could use imaging if you'd like to correct any positioning.
What do you mean you can use imaging?
To make sure you're in the correct spot and not in the street. So that's four of them.
If you're a medicine doctor, you can put an ultrasound guided cath in the shock room, you just need to know your anatomy and you're going to go. So I agree, you were right in the fourth to fifth intercostal space. I tunnel mine, some people don't. So what that means is I will make my incision in the fifth to sixth intercostal space and tunnel up one rib. The reason I do that is because these chest tubes fall out, just came out, magically aren't there anymore. When the patient gets up to the floor and the nurses are turning them or PT's trying to work with them, they come out. If they come out and the hole that I've made into the thoracic cavity is right underneath the hole, the incision that I made, when it comes out, it's an open sucking chest wound, right? If I tunnel up, there's a flap over it. So yes, they can still get a pneumothorax. They probably will get a pneumothorax, but it's typically not a sucking chest wound. However, when I'm teaching young people to do it, I don't do that because they jack it up every time, but I personally will tunnel up one rib space. You always want to make sure when you're popping in, you pop in just on top of the rib, because remember the nerve, artery, and vein that lies with every rib is on the underside of the rib. So if you pop in and hit that artery that's on the underside of the other rib, so if you come in under the rib, the intercostal vessels bleed a lot, and they're very, very difficult to control when they bleed. That's the most common reason that the ED calls us when they put a chest tube in and it's bleeding, is because they hit the intercostal. So I can take them to the operating room. If they're not super hemodynamically unstable, I can send them to IR, but in the middle of the night, that's a hassle and a pain in the butt. So the other thing that I do, what I usually have to do, and it's awful, is make a slightly bigger incision. And then I take a 3/0 vicryl suture on a big old honking needle, and I do a figure of 8 around the rib, away from where they made it, and so it will pinch off that vessel on either side of wherever they dinged it. It's tough. You can ding the lung doing that. It's not one of the things I usually let the residents do, and I get annoyed when I have to do it, but this is why it's really important to come in just right on top of the rib, pop in, and spread really hard. The other thing to remember is that, again, kids have a very, and kids, by kids, even 19-year-old dudes or girls have a very pliable chest wall, so you're trying to pop in with this clamp, and the whole chest wall is caving in, and it makes your butt pucker a little bit, and you get kind of nervous, and so the trick to that is to use a sharper instrument. Normally I go in with a Kelly clamp, which is a big, thick, blunt-tipped clamp, but I'll use a hemostat or something that's a little pointier to get in if they have a pliable chest wall. All right, so treatment of a hemothorax is always going to be a chest tube. We'll talk about incomplete drainage and what we do about that in a little bit here. Pulmonary contusions. So this is something that we see a lot of. But a third of patients will come in and get a chest x-ray and it looks pristine in the shock room. What do you suppose that is? What is a pulmonary contusion? The layman's term. Bruise. Yeah, it's a bruise in the chest, right? I punch you in the arm, it's going to take a little bit of time for that bruise to develop, okay? So you're not going to see it right away. So our transport times now are so fast that these patients get to us within a matter of minutes, usually less than 30 by the time they get to us. So the first chest x-ray is oftentimes very normal. It usually takes somewhere between 4 to 6 hours to see something blossom. If you're already seeing it, you need to be a little worried because like any other bruise, it's going to continue to blossom. So they're going to be someone that needs to be in a closer monitored setting, keeping an eye on them because they could get into some respiratory distress as this bruise blossoms over the next 6 to 8 hours. And again, understanding that just as long as it takes for an x-ray to show the image, a lot of times the image itself stays looking terrible for long after the patient themselves actually looks better. So it all needs to be based on what the patient looks like. I will usually tell people that the patient will manifest signs of pneumonia with secretions, coughing, things like that, fevers, a leukocytosis long before the x-ray ever looks bad. And then they will be looking better and off oxygen, no secretions, everything in the chest x-ray still looks kind of crappy. It's the same thing with pulmonary contusions. It takes a little bit for the chest x-ray to show up, takes a little bit for the chest x-ray to go away, and the patient's usually somewhere fluctuating in the middle of what's actually happening on the imaging. So how do we manage pulmonary contusions? Basically, you want to try to keep these patients as euvolemic as possible. You don't want to overload them because we can throw them into ARDS. They can have worsening respiratory function. Understanding that as this bruise manifests and develops, that lung sort of becomes firm where the bruising or the contusion is, and oxygen passage is not as good through the alveoli in that area. So postural therapy, sit them up, turn them on their side, get them off of, usually if you can get the bad lung up and aerate it a little better. Now, if they're really, really sick and that bad lung's not working at all, you want to put the good lung up because that's the lung that's oxygenating and working well. But getting the bad lung up will help drain some of that stuff and hopefully allow it to aerate and open up. If you have to put them on the vent, you want to optimize your PEEP and be cautious with too much tidal volume because, again, that lung is firm. If you give them a bunch of tidal volume, you can actually pop it and cause a barotrauma or a pneumothorax. Rib fractures is going to be one of the most common things we see. We see them every single day. But the majority of people do not die from a rib fracture. The majority of people die from the associated injuries with a rib fracture. So these are the people that have associated abdominal trauma, head trauma, spine trauma, and things like that. This is a very ominous sign in children because, again, there's probably some underlying issues because of the force required to break their ribs. But the one thing that this used to impress me, I used to do a lot of lecturing on elderly trauma, mostly because I would refuse to do everyone tried to give me pregnancy and trauma because I was a girl. So I would do elderly and make the dudes do the pregnant trauma patients. But the thing that's most impressive is once you get, again, we define elderly as 65 or older. Once you get into that age bracket, every rib fracture in and of itself constitutes an 11% mortality. Not morbidity, mortality. So if they break 5 ribs, they got a 55% mortality. So rib fractures in the elderly population are a big deal, okay? These patients, again, have minimal ability to compensate, usually have some underlying pulmonary contusion. They are at very high risk for developing pneumonias, being unable to clear their secretions. Pain control is going to be an issue with them because the things that you would give the younger people makes the older people delirious. And delirium in the ICU or delirium in the hospital is also catastrophic for elderly patients. So finding the balance between pain control, getting them to breathe, and not altering their mental status, and then putting them at risk for aspiration and the other things that go along with that are a big deal. They're also a little more sensitive to the narcotics in terms of it causing hypotension, leading them to have acute kidney injuries, cardiac compromise, MIs, and things like that. So rib fractures in the elderly patients are a big deal, and we have pretty much if I have a patient over the age of 65 with more than 3 ribs, they at least go to a step-down unit. And oftentimes I have a pretty low threshold to put them in the ICU, especially if they have any other associated injuries. Now the ICU team in the morning is like, you sissy, why in the hell would you put that person there? I'm like, give them 12 hours, and usually they'll end up intubated or something like that. So the associated injuries are the things we all know about. Pulmonary contusions or lacerations. Typically, if a rib lacerates the lung, I mean, that's how you got the pneumothorax probably, unless they had a bunch of blebs from COPD. But if the rib lacerates the lung, usually, unless the rib is grossly displaced and poking in at the lung, that's going to seal up and heal all on its own without any sort of intervention whatsoever other than the chest tube until it gets a chance. Sometimes, if they're bleeding enough, I will take them to the operating room and close it, but for the most part, no, especially for blunt trauma. Hemothorax and pneumothorax, you're obviously going to drain with the chest tube. There's up to 56% of patients with lower rib fractures have a liver lac and 28% have a spleen lac. I'm trying to remember. I think I'll go into it a little bit more later. But how do I decide? And almost never am I going to the operating room for blunt trauma with a hemothorax. But how do I decide? Do you have any idea when I put a chest tube in a patient, what number of bloody output coming out of that chest tube would make me say, I'm going to the operating room. This isn't something I can sit on and watch.
At least 2 to
Huh?
At least 2 liters? 1 liter?
Yeah. True ATLS says 1,600, that's a stupid number, so we all go with 1,500 because for some reason that's more normal. But 1,500 mils output on initial insertion of a chest tube, you should be going to the operating room. Don't pass go, don't go to IR, don't do any of the other cute stuff. Okay? Or more than 400 mils or 200 mils, we'll go 200 mils an hour for 2 or more hours will drive you to the operating room. Okay? So let's say you dumped out 800 initially, and then over the next hour you dumped out another 200. I'm not going to rush to the operating room right away. Even if I dump out another 400, unless the patient is hemodynamically unstable, I'm not going to rush to the operating room right away. I want to see what happens over the next hour, so at least 2 hours. So then if of the next hour they only put 100 out, then I'm just going to keep watching. If they put another 300 out, then we're going to talk about going. And the reasoning behind that is because especially in the initial exam, they get moved around and rocked around so much that we turn them and get them on and off the CT table. We turn them and change their sheets because now I've poured blood all over their bed, putting the chest tube in. And doing all of that by gravity, most often they will dump a lot of what was retained in there that didn't come out initially. That's why I want to see what happens for a couple hours because it shouldn't continue to happen. A flail chest is defined as 3 consecutive rib fractures in 2 or more places. So you have a segment of the rib or the chest wall, I'll show you some real life pictures of this in a little bit, of the chest wall that moves independently of the rest of the chest wall. Okay? So remember, when I'm taking a breath in, I have negative intrathoracic pressure. My chest wall expands as the air comes in. Well, that negative pressure in there is going to suck on that piece of rib, that piece of chest wall that's detached, and suck it in. Okay? And then when I exhale, I have positive pressure, so the rest of your chest wall is going in to help push that air out, but that flail segment is going to poke out because the positive pressure pushes it out. So the flail segment moves opposite of what the chest wall moves. It's not super common, but does happen in about 5 to 13% of patients, and it's usually lateral and low. Okay? Anteriorly, you're protected by the sternum. Posteriorly, you're protected by the spine. Low, really, you're not protected by a whole lot of anything. And then out laterally, you have just a lot of room there where it can fracture. So it's usually sort of anterior, lateral, and low. Again, it's more common in elderly patients because their bones are more friable or pliable, or not pliable, they're not pliable, frail, thin. And thin people it happens more commonly in. It's gunshot wounds to the belly and rib fractures are the one time where it's actually beneficial to be chunky. Because on occasion you can miss getting into the abdominal cavity with that. The problem with flail chest is disruption of the chest wall mechanics. So it alters your tidal volume and your functional residual capacity. But more importantly, there's almost always an underlying pulmonary contusion associated with it, right? You had a hard enough force to break a chunk of your rib cage off and separate it from the rest of the chest. There's going to be a big pulmonary contusion underlying it. And that causes increasing sputum production and inability to cough. They don't have the ability or the force to cough. They have a lot of pain control problems. They get collapse or atelectasis, and they're at high risk for pneumonias in the atelectatic areas of the lung that they're not re-expanding. So, mainstay of therapy with rib fractures is going to be pain control. Okay? How you control their pain depends on severity of injury and the patients themselves. So the narcotics abusers, the methadone, methamphetamine, heroin abusers, incredibly difficult to control their pain. Like, you're giving them narcotics that feel like you should be putting down a horse with them. So we start with PO and IV narcotics. If the patient is allowed to have NSAIDs, as in they don't have GERD, kidney disease, or anything like that, we go with NSAIDs, usually Toradol, if we can give it to them. Intercostal nerve blocks are a nice thing. The problem with an intercostal nerve block is that each and every rib has its own nerve that goes there to it. So when you do an intercostal block, you have to block each and every rib that's fractured, which means the patient gets poked a lot. They don't enjoy that. It only lasts 6 to 8 hours, so then they have to come back and get it done the next day, which isn't very fun. And it can be tough to get to some of those, especially some of the posterior fractures that are under the scapula and stuff like that. It's tough to get to them and control them. Subcutaneous pain catheters or on-Q pumps. Again, it's something you put in the sub-Q and it just sort of continuously leaks lidocaine. That's usually what we put in them. But it's hit or miss. I don't think they're great. I don't actually use them anymore. I used to do them a lot when I plated ribs back in the day. but I really don't use them. My mainstay is if a PCA or PO or other IV narcotics don't work, I go with a thoracic epidural. You can't do the thoracic epidural in a patient who is intubated because when it gets put in, you need for them to be able to participate in an exam to tell you they can feel their feet, they can feel their toes, what they can and can't feel. But the thoracic epidural has become something that we do a lot of now to try to avoid intubation. So if you can control their pain, then they will participate with pulmonary hygiene or pulmonary toilet. So getting up and moving around, taking deep breaths, using the incentive spirometer, using the flutter valve, or doing their easy PAP. When they hurt, they won't do that. They splint and then get pneumonias and other issues. Non-invasive positive pressure ventilation would be CPAP, BiPAP, something like that. That's not something you could actually do to someone for an extended period of time because their face will break down under the mask too. So, and also if their mental status is iffy at all, you want to be cautious with that because you're blowing a bunch of air in their stomach and you're putting them at high risk for aspiration. So I usually will not do non-invasive. If they are failing epidural or they're not a candidate for an epidural, like they were on blood thinners or something like that, so anesthesia won't put it in, then I usually will go to intubation. Surgical rib fixation is something that we all talk about. It was a big deal for a while. We did a lot of it, and then it sort of, I will say in academic institutions fell out of favor. In private institutions, it's still a big thing because you can bill a boatload of money for rib fixation, but it's never truly been proven to, this is a joke. People don't get it, but this is one of the surgeons at a different hospital who used to fix every rib. The residents laugh, but I should have taken him out for that. He's a really nice guy. So, you know, the thought process behind it is if you have ribs that are broken and they're moving every time you take a breath, I can't splint your ribs like I can splint your arm. So they move every time you take a breath. It hurts all the time, and there's not a lot you can do with that. So the thought is if I go in there and I plate them and stabilize them, then it'll improve pain control, it'll improve the respiratory mechanics, they'll come off the ventilator earlier, and things like that. And it's never truly been shown to do much of that. I will tell you that I've had people off the ventilator who someone took them and plated their ribs and they came back to be on the ventilator. I'm like, well, that kind of defeated the purpose of it. It's been probably a year since I've plated anybody, but I plated a lady simply because she got run over by a pickup truck and crushed both sides of her chest. And they were so misshapen and deformed that every time she took a breath it hurt and I couldn't get her off the vent. We plated her ribs, and the side we plated feels better now, the side we didn't doesn't. I don't think it got her off the vent really any sooner. I think it might have helped her long-term pain, but I'm just not sure it's worth the risk associated with it, so it has to be a pretty specific case before I'll agree to do it, but it's something that you should have in your knowledge base because a lot of patients read about it and they'll come in with their one rib fracture that they got from getting kicked by a horse and try to talk you into plating their rib. The answer to that is no. Whoa. Ooh, that's my favorite meme. Signs of an air embolism. So not something we see a lot. A lot of times this is a diagnosis of they're already dead and I have nothing else to blame it on. But if they have seizures or sudden cardiovascular collapse, concerns for an air embolism. The one that I'm pretty sure, it was either an air embolism or a bullet embolism, I don't know. But my very first call as an attending surgeon, God hates me because I'm kind of a terrible person, I got a gunshot wound to the heart. And I was already rolling upstairs with a gunshot wound to the belly, so I had to call in one of my partners, thank God, to tell him that I needed him to come do one or the other. And so he showed up just in time as I have the chest open and I'm staring at the pericardium that's full of blood, and the guy, his blood pressure's like 60, and thinking, the minute I open this, the shit's gonna hit the fan. And so I'm taking a deep breath, trying not to poop my pants, I'm getting ready, and my partner's like, what are you doing? I'm like, oh, thank God you're here. So we opened it. He had a big hole in the left ventricle, and we put some pluginated sutures in. It went really well. Problem is, if you get shot, right, there should be another hole somewhere. And so we're looking all around, and I can't find another hole anywhere. I got the fluoro out and we fluoroed it because they've been known to embolize down into the vessels. Like if it drops down the IVC, it can go down into the vessels, which doesn't make sense from a left ventricular injury, right? So that should be in the aorta somewhere. I don't know. But I could never find the bullet ever. But the guy's alive with a blood pressure of 120 now. We're like, sweet. So close. I was literally putting sternal wires in, getting ready to close him, and he just died like a dog. So we could never really make sense of it because in theory that was the left ventricle. If the bullet was going to go anywhere, it was going to go out the aorta and down into the iliacs, right? A bullet should not be able to make it up a carotid into the head, and it shouldn't go into the lungs from the left system. So our only thought process was that he had a bad air embolism from that, and he died. We went Pulp Fiction style though and straight stabbed epi directly into his ventricle. That doesn't work either. So,
Did you ever find the bullet?
no. I actually did. It was down in his leg somewhere because we had him, he got an autopsy. So they found it in his leg. Huh?
You know, low caliber?
It wasn't very big because if it made it that far. Because I stopped at the iliacs, but the vessels get pretty small after that. So it could have been a piece of it too. I don't really know. I get asked that a lot by the families. What kind of bullet was it? I'm like, I don't know. The kind that kills, like the kind that causes bad injuries. Sometimes I'm like, it's a big one. So you can see froth on an ABG. You get a VQ mismatch. The thing that people like to test on, but again, I've never seen it, is a mill wheel murmur. This is very specific rumbling murmur that you can hear when you listen to the heart. This happens very late in the course. And typically if I had no suspicion for an air embolism, I'm not listening for a murmur. So I've never seen that, but that showed up on all of our tests. They really like to talk about that. Treatment of an air embolism is immediate thoracotomy. If you're already in the chest, you can try to aspirate the air right out. You stick a needle in the ventricle and just aspirate. And you keep pulling back until you get blood and not just a bunch of bubbles. You want to put them in left lateral decubitus position. You want to put their head down and their toes up, because if you can get the air to go to their toes and not to their brain, it's a better option. Hyperbaric oxygen we talk about, but we don't really do. Methodists used to kind of do it, but they don't do it anymore either. But that's an old treatment for it. Big thing is high flow oxygen, so put them on 100% oxygen and minimize their airway pressures if you can, and sort of treat them like their ARDS or trying to avoid lung injury, so small tidal volumes. Tracheobronchial injuries, this is that same thing I showed you earlier. Again, remembering blunt injuries tend to occur more at the carina or right at the takeoff of the main bronchus, whereas most penetrating injuries happen in the neck. So tracheobronchial injuries, these are one of the things that I absolutely detest. They're tough to control, they're tough to deal with. You can see pneumomediastinum or pneumopericardium on a CT, unexplained. You put a chest tube in and they have a continuous air leak. So typically if you put a chest tube in and they have a pulmonary laceration or something like that, you should see an air leak when they exhale. So when they exhale, that little tiny hole in the lung will blow air out of it and you'll see a leak in the chest tube. Have you guys seen many chest tubes yet? So it comes with this canister. I might have a picture of it somewhere down the road. This thing, it's called a Pleurovac here. And so this is where the blood fills up in these, and that's how we monitor how much is coming out. But this little guy right here is how you test if they have a leak. Can you see that mouse? Yeah. So if this fluid in here bubbles, they have a leak of some variety. So when a patient exhales, if there's no leak here, that's when we can start talking about when we can take it to water seal or when we can take them off suction or even when we can remove the tube. If it's leaking or bubbling here, you have to be concerned that there's some sort of leak really. And in theory, it should only leak. And now, if they're on positive pressure, so if they're on the vent and getting a bunch of air blown in, it can leak a little more consistently. But if it's leaking all the time, you have to worry that it's leaking from somewhere else, that this is not just a tiny lung laceration. Oops. So you put a chest tube in and it's a continuous leak, not just with expiration. It's not a small leak. It's pretty epic bubbles in there, just bubbling away. And after you put the chest tube in, all of a sudden their dyspnea is worse. And it's worse because now it's sucking all of this air out, and so they start breathing faster, but it's sucking this air out as it blows out. And then you put them on the vent because they have worsening dyspnea, and that's what we do because we do the ABCs over and over and over. And now you're blowing positive pressure in them. You've made the air leak worse. You've made the tachypnea worse. You've made them lose, and they start desatting. It's a vicious cycle. So how do we treat them? If it's a teeny tiny injury, less than a third of the circumference, which how would I know that? How would I know how big the hole is?
I'll say by how much does it
It's going to be hard to say. Because I can't really quantify a leak because all I can quantify are bubbles. Right? It's not like there's a number that says, oh, you have this many bubbles and that's a 20% leak. So I just see a lot of bubbles or a little bubbles. How do I assess a hole in the trachea? What kind of imaging? CT, unless it's a big hole, you're probably not going to see it much on CT. What you'll see are air bubbles in places you shouldn't see them. But if it's a big hole, you're also going to see just like air tracking all around it. So what other kind of imaging can I do to look at the airway? Huh? Well, EGD is going to show me the esophagus and the stomach. So I look at the airway. Scope, yes, bronchoscopy, right? So high index of suspicion, we've got our CT, you see air in places you shouldn't see air, then, especially with penetrating trauma, the things you're worried about are injury to the esophagus and injury to the trachea. So you're going to do what we call triple scoping. So you're going to do a DL, or direct laryngoscopy, and look at the larynx and make sure you don't have a hole in the larynx. You're going to do a bronchoscopy and assess the trachea all the way down. And then you're going to do an EGD because you also want to look at the esophagus and make sure you don't have an injury. The other thing you could do if you don't want to do an EGD, if you're being that person, you can do a gastrograph and swallow and make sure they don't have a leak. An EGD is going to be a more definitive, better study. But if you're not good at it, it's not a better study. So if you think, wow, I really suck at EGDs, maybe I should be the one to do it, and GI is not going to come in the middle of the night to do it, then I would do the swallow study. So I did a bronch. I see a small lesion, and I got really excited because now I don't have to operate, right? So now if the wound edges don't look all macerated and nasty, then I can just put them on voice rest, put them on some antibiotics. I don't have a bunch of associated injury. Now if I have a hole there and a hole in the esophagus, we're operating. But if that's the only thing I have, I'm going to try to avoid mechanical ventilation if I can. I'm going to try to avoid slamming positive pressure at this hole. Put them on humidified air and voice rest. You want to try to minimize what's going down there. You don't want the area to dry out. Put them on a PPI, and then repeat the bronchoscopy in 5 to 7 days and assess it. If it's no better, then you may have to talk about operative intervention, which will really stink at that point because now you've been leaking secretions into your neck for a week, and it makes the operation more difficult and a higher likelihood of breakdown. But typically you would know before then if they're not tolerating it, if they're having more sub-Q air, their eyeballs are swollen shut now from all the crepitus, and things like that. All right, we're almost done, I promise. There's a couple cases. Somebody had a question, I thought. Yes?
Wouldn't a bronchoscopy just run the risk of making the air worse?
Well, you have to be careful.
Throw that way.
No, you just go in slow, right? So EGDs are a little, so with bronchoscopy, I'm not blowing a bunch of air in there, right? So if I'm scoping or doing an EGD, I'm blowing a bunch of air in there, so I can make the rip worse if there's a hole in the esophagus. But at that point, neck exploration for an esophagus versus a thoracic exploration of an esophagus is way more invasive, and I'd rather subject them to potentially making an injury worse than subjecting them to a huge operation. Bronchoscopy is a little different. So a lot of times when I'm doing EGDs, I blast all the way into the stomach and then watch everything as I back out. You do a lot of that with colonoscopy too. So I blow it up and back out and watch everything as I come out. So certainly if I went in blind and hit some hole and did something stupid, I can cause a problem. Bronchoscopy, the airway is open. It's always open. I'm not blowing a bunch of air in there. So I watch everything as I go in and as I come out. What can obscure your vision is if they're already intubated and you're going through an ET tube, there could be an injury above that. So you can miss an injury, but usually, as long as you're paying attention to what you're doing with bronchoscopy, you don't make it worse. Anybody else? Okay, so this is a real life case of a lovely, lovely human who was a 19-year-old gentleman who was the passenger in a car on the interstate who heard multiple shots and told first responders that he couldn't breathe, and he had a bunch of back pain. So when he showed up to us, these are his vital signs. How do you feel about them? Feel good about them? But he just told you you can't breathe. Yeah, I mean, I'm pretty pleased with him, right? This isn't something that I'm like, pass go, let's head to the operating room. This is the guy that I'm going to work up a little bit and figure out what's really going on. So, like a good resident, my resident listened to him and says, wow, he's got decreased breath sounds on the right. We roll him, because that's what we do, and he's got 2 gunshot wounds to the right back and a huge hematoma on his back, around his scapula. So, why don't you tell me the differential diagnosis? Heard hemothorax, I heard mumbles, tension pneumo. Whoa. If he had a tension pneumo, I would expect his vitals to be a little bit more concerning, but not always. He's young. He certainly could be compensating. But we'll at least say pneumothorax for sure. Anything else? Rib fractures, yeah. What other bones could be injured back there? Spine, scapula. Huh? Could be, yeah. If it's low enough, it definitely could be.
Would you, if patient had pericardial fluid with tamponade, would you though be looking more like hypotensive and probably a decreased heart rate at that point?
If they truly had tamponade, yes. There's a
Okay.
lot of times we identify pericardial fluid that is blood and does need operative intervention, but hasn't reached the point of tamponade yet.
So you wouldn't see really a decrease in vital signs even if you had a little bit of pericardial, like edema?
Potentially not, especially in a young guy, because he's going to compensate well.
Okay.
I will tell you that if I know, like if I put the ultrasound on him and he's clearly got something in his heart, I actually try to run them a little hypotensive, right? So if I push their pressure at all, if I blast him with a bunch of fluid and push his pressure, he's going to blow off any clot that he has. It's going to increase his pressure and he's going to worsen it, and he probably will have tamponade. So I allow for permissive hypotension in these people that I'm worried about. Yes,
Does this patient have exit wounds?
he's got 2 holes on his back. As a physician or a PA or a NP or anybody who manages patients, unless you really want to get tangled up into some difficult discussion in the courtroom, you don't ever call anything an entrance or an exit, ever. You just say they have 2 holes.
Do they have a hole on their anterior portion?
Nope, there's just these 2 holes in the back. So probably he got shot twice, right? Unless it skived everything and went through. I'll tell you, this kid was skinny, so that would have been tough. All right, so hemothorax, pneumothorax, that's what we talked about, pulmonary contusions and lacerations. Great vessel or cardiac injury, we don't really know where that was. I'm going to show you an x-ray that's pretty scary in a second here. Rib fractures we talked about, can be scapular fractures, spine fractures, could even be a sternal fracture if it came anteriorly. And then again, intercostal vessel injuries, those can bleed something fierce. So typical trauma labs include a CBC, CMP, coags, and type and screen or cross, depending on how much I actually think they're going to need blood. You understand the difference between screen and cross, right?
Yeah.
Okay, so I'll ask for whatever. We always have a lot of blood available. Every trauma patient gets an ETOH and a urine drug screen, and if you're a lady, you get a UPT. Apparently, even if you're 85 years old, you get a UPT, which makes me crack up every time. Anybody know what this is?
Yes.
What is it?
It's a subcostal view of the heart. And there's
How do you
fluid.
feel about it?
What?
How do you feel about it?
There's fluid in the pericardial area. You can tell by the anterior to, it's not posterior to the.
By the arrow sign?
What?
You can tell by the arrow sign.
Oh, yeah, and the descending aorta.
So there's fluid here, there's fluid up there. That's very concerning. I forgot to put the arrows on there. I try to take a lot of them off. It's very concerning. So if I saw this was not his. I just wanted to show you that. If I saw this, I would be alarmed and know that we're heading to the operating room reasonably shortly. If he had those vitals and this image, This is a lot of fluid, so I would expect that he's pretty compressed and I would need to see a dynamic view of it. But if I saw this image and his vitals were what they were, I would consider a pericardial window first. But it's hit or miss. I don't think anyone would fault you for going straight to sternotomy. And then depending on his stability, obviously because this was a gunshot wound to the back, I'm going to do a chest x-ray. If I don't see any bullets, I'm going to do an abdominal x-ray and continue working my way down looking for bullets, because it doesn't make sense to me that someone would have 2 holes right here and no intra-abdominal injuries or anything like that. But a chest x-ray is going to be the first thing. You fast them, so you're going to look at the belly, you're going to look at the heart, and then if they're stable, then I will CT or CTA them, CT angiogram depending. So this is his actual imaging. This right here is a lead, so don't worry about that. But this is all bullet fragment. This is a big hunk of bullet. There's a hunk of bullet there. So this came in through his right back over here somewhere, and is sitting right here. That's a little concerning. Jeez Louise. He is hemodynamically stable, so I'm not going to get crazy. If he was hemodynamically unstable, one shot you could do is a cross-table lateral to sort of see if that's anterior or posterior, because this is an AP view. You're shooting from top to bottom. So it's really, I have no idea where that bullet is within. It could still be in his back, and I don't know that. But because he was stable, we scanned him. So you can see that he quite clearly has a rib fracture here. He has a transverse process fracture of his spine here. This here is all blood, this dark part down here. This is crunched up lung right in here. That's some bullet fragment there. This is all hemothorax here. So treatment of him, he got a chest tube in that right side. And then this is sort of the stuff we talked about a little bit ago. If he's hemodynamically stable and you see signs of active extrav on CT, so if it looked like an intercostal was bleeding or something within the pulmonary parenchyma was bleeding, he's totally stable, I would consider sending him to IR for a formal angiogram and see if they could embo something rather than rushing him off to the operating room and subjecting him to a thoracotomy. However, if he's unstable, or if the initial chest tube output is 1,500, or what we talked about, greater than 200 for 2 to 4 hours, then we have to go to the operating room. Now, if I think that there's a pulmonary injury, I do a thoracotomy. I think if it's a cardiac injury, I do a sternotomy. It's difficult to get to the lung from a sternotomy. It's difficult to get to the heart from a thoracotomy. Both can be done, but there's no reason to do it wrong. Trauma patients will always get an anterior lateral thoracotomy if it's their initial operation. So a true thoracotomy, you put the patient up in lateral position, and it's a posterior lateral. You want to put their arm up, you roll them up, and you make your incision posterior lateral. Trauma patients, I don't do that. I put them flat on their back, especially if I've never imaged them, because number one, I don't know what's happening in their belly, and if I may need to come down into their belly, and if they're up lateral, I can't do that. Number two, they may have a spine injury, and I want to protect their spine, and so I don't want to roll them up and have their spine torqued during the case. And number three, if the problem looks like it goes into the chest or any other place, I need to have them available to clamshell, which means take that thoracotomy all the way across the other side and lift their chest up like the hood of a car. It's really hideous incision. It's a lot of fun to do. Typically, if we're doing a thoracotomy, they aren't doing well. So those are indications for operating room. This kid never went to the operating room, but that would have made it boring. So we talked about that already. There's different things you can do. So this is a picture of the thoracotomy here. This is anterior lateral. This metal thing is the Finicetta retractor. What you're seeing here, this thing is the lung that they're shoving up out of the way. This is the mediastinum and pericardium. This is a hole in the pericardium, which is always concerning. Can you guys see that? So this is lung here, shoved up out of the way. This is mediastinum, and that's a hole in the pericardium. So you're going to open the pericardium on this patient and take a look at the heart, because more than likely they have an injury to the heart. Almost never do I do video-assisted thoracoscopy up in the initial operation. That's what we call VATS. It's basically laparoscopic surgery in the chest. About the only time I do that is if a patient has a retained hemothorax. So I put a chest tube in it dumped, I get a chest x-ray the next day, and it still looks cruddy. It still looks like there's a retained hemothorax. The answer to that is never to put a second chest tube in, which is what everyone will say. That's the wrong answer. If the chest tube didn't drain it, then the right answer is to take him to the operating room and wash it out. At which point I will usually I put 2 chest tubes in, then I'll put another long one in up angled towards the apex, and then I put a right angle chest tube that lays right over the diaphragm, because when patients are laying flat on their back, everything goes posterior and it rides along the back, so you want the straight chest tube that goes up towards the apex. But as they start getting up and getting mobile, everything's gonna fall down, and that's where the angled chest tube comes in, and it'll clear everything up off the diaphragm. Antibiotics are typically not required. Now, if they had a diaphragm injury and their colon or their stomach or something was injured and up in the chest and secreting enteric contents into the chest, I'll consider 24 to 48 hours of antibiotics after that. But typically for a true thoracic injury, I usually don't do antibiotics. Now, some of these people have big holes, like we had a guy with a big tree branch in his chest, and so when we removed the branch itself was dirty, but there's also pieces of his clothing stuck in his chest, which clearly wasn't dirty. We left him on antibiotics for a little bit longer. But most of the time, chest wounds aren't too bad. And realistically, bullets are so hot that they sort of burn any sort of infection. So we typically, even with orthopedic injuries, typically don't treat with antibiotics for open fractures or bullet wounds themselves, unless there's enteric injury. Drains, so if I open the pericardium, they're gonna get a pericardial drain. You can use it as a chest tube. I usually use a JP, which is smaller, flexible, not as painful tube. And then they're certainly gonna end up with a chest tube. So complications of either the operation or just a hemothorax with a chest tube placement is a retained hemothorax, which I'll show you a picture of in a second, or empyema, lung entrapment, which will cause persistent pneumothorax because the lung just can't re-expand, or bronchopleural fistula. If you have diaphragm injuries on the right side, even worse is when you get a fistula between your bile and your chest wall. It's terrible. They're tough to deal with. Patients get very sick from that. Then bile sits in their chest, then bile obeys their pericardium, and then they get arrhythmias, and it's really awful, as is this computer. Questions about penetrating? Yes?
This might be maybe a question, but what are you doing to maintain like a visual field? Like how were you able to find that small little hole in the pericardium or the mediastinum?
This beautiful retractor.
Okay. And then what's stopping the blood from going and blocking your vision or?
My finger, eventually, once I get it in there. So if I saw this, God damn it. If I saw this and I was doing a thoracotomy, I would actually come up with a sternotomy because I have a better view of the heart here. So they're gonna end up with a really painful incision, but I wanna control this to the best of my ability. Thoracotomy I do in the emergency department, so if they came in and the paramedics told me that they lost vitals within 5 to 7 minutes of arrival, then I will cut their chest in the ER. I actually have very, very strict requirements for when I will cut a chest in the ER. So ATLS teaching is 15 minutes with loss of vitals. My partners and I all agree that 10 minutes is max. I don't ever cut for blunt trauma. So it's gotta be penetrating trauma, less than 10 minutes. And I've actually gone to the point where I will slap them on the monitor, and if they're asystole, I'm not doing it. If they're narrow complex PEA of any variety, I will cut. Asystole, you're never getting them back in that instance. So if I cut in the ER, it's a thoracotomy. So if I cut them, and this is more what this picture is. So I did an anterior lateral thoracotomy. I put this big honker in, which is called a rib spreader or a finichetto. I take down the inferior pulmonary ligament because the lung is stuck down to the diaphragm down there. I just cut it with a pair of scissors, shove the lung up, and look at the pericardium here, okay? It doesn't show it well, but usually you'll see the phrenic nerve sort of laying right here. I cut above the phrenic nerve, long ways above it like this, and then I eviscerate the heart from the pericardium and take a look. I will tell you that gunshot wounds suck. Stab wounds are a little bit better. They're easier to control because the gunshot wound blows a hole in it. The stab wound usually just pokes it. So as soon as I eviscerate it, I'll put my finger on it, and then I decide how I want to control it, okay? How I control that is different in the ER versus when I'm in the OR. So the 3 ways I can temporize it or control it are staple it with a skin stapler, which I will tell you that is much more difficult than one would think when a heart is beating and you're trying to staple it and you're like chasing it all around to staple it, and it's slippery. You can staple it. I can stick a Foley catheter in it and blow up the balloon, okay? But then you have to be able to retract on the Foley a little bit, because if you let it go, it will suck in and it will bleed all around the catheter. Put the Foley in, blow up the balloon. We have an adapter that hooks the Foley catheter right up to the level 1, so I can actually transfuse directly into the heart. So there's pluses and minuses to it, right? Someone has to stand there, someone has to not yank it out, someone has to not let it fall, but it's a great way to get blood into the patient quickly, and then get them up to the OR. Or I can suture it. I try not to suture in the ER because I typically like to do pledgeted sutures, which have these little like felt pads basically on there, so the suture doesn't just rip through the muscle. The felt pads protect it. And I don't want to do that down in the ER because that's dirty and contaminated, and now I'm leaving a foreign body in their body that has these dirty felt pads on it. So my typical solution is to put the Foley in, transfuse, get up to the operating room, and then I will sew it up in the operating room. If I'm already in the operating room, I use my finger to control it the whole time, and every so often the resident tacks me to the patient, which is unfortunate and it hurts. So I just will say, are you ready? And when they get all set up and they're ready, I'll have the sucker, and I take my finger, I suck while they're throwing their stitch, I put my finger back on while they're getting their pledget set, and then when they go to tie down, I'll move my finger again. So it's not real high tech. All right, last case, and I'm not getting you out early, I'm such a liar. This isn't her car, but this is a true story. A 19-year-old girl's car stalled out in the middle of a 4-lane highway, and rather than sit in her car and call for help, she gets on her phone, gets out of her car, and got smoked by a dump truck. Really terrible. First responder arrival, she's hypotensive, hypoxic, and has a GCS at 8. She shows up in the shock room with a blood pressure of 95 over palp, a heart rate of 152. She's saturating 60% on 100% non-rebreather mask, and her GCS is 8. Feel good about her? Nah, me either. So she got immediately intubated. Again, you have to be cautious when you do this because giving her drugs to intubate are going to tank her pressures, right? So before you do that, make sure you have great access, make sure you're already getting blood products going in her, you're resuscitating her, and you're very cautious with your drugs for intubation. So these are the patients that I do not do the standard sucks and etomidate. You think about ketamine and sucks or something like that, but what you don't want to do is truly tank her pressures because you're going to struggle to get her back. When you looked at her chest wall, you clearly saw asymmetric respirations. She had a bunch of facial abrasions. Her right lower extremity was mangled up. Differential diagnosis is going to be the same as the other guy. Trauma labs are the same as the other guy. Except in her, she automatically gets a chest and a pelvis x-ray. So blunt trauma typically will get a chest and a pelvis. She got a fast exam, and then we went straight to CT. This, I cheated and showed you already, is one flail segment. She had one on the other side posteriorly too, but you can see the ribs are fractured here, up, and then right here, down. So this segment of her chest wall moved independent of the rest. This is the spine board behind her. That's what you're seeing. And this is her images. So she had bilateral pneumothoraces, which you can see this whole lung right here is collapsed down. Here's some pneumothorax on this side here too. There's little bits of it here that you can see, some down here. This is all pulmonary contusion and blood up here. This is the totally collapsed down lung on that side. This is pulmonary contusion. All this speckly white stuff out here, this is sub-Q air from her pneumothoraces. She has a bunch over here too. But she had, on the right side, she had ribs 2 through 7 broken. On the left side, she just had a posterior rib, clavicle fracture, transverse process fracture, sternal fractures. And then she had chest tubes. We had a lot of trouble weaning her off the vent. She was really young, she was really thin. There was a lot of anxiety issues associated with it. We actually trached her pretty early because we knew she wouldn't be quick to extubate. And we could never really get her off of volume support, which is a spontaneous mode, but it's not a mode that I will extubate from, okay? So, do you guys know much about vent at all? Okay, so there's what we call the patient being on a rate, meaning the vent is set, it will breathe for them every 16, 18 times a minute, whatever it's set at, or they're spontaneous, where the patient decides that they're going to initiate the breath. The vent will not initiate the breath unless they go apneic, then the vent will go into backup mode and initiate. But the patient has to initiate the breath. And once they decide to take a breath, then the vent will support them in whatever way we've set it up. So most of the time we set it up with pressure support. So the patient will take a breath, and then we'll have them on 10 of pressure support to sort of compensate for the tube, because the ET tube feels like you're breathing through a straw. Or if the patient has been intubated for a long time, has a lot of chest trauma, is super old, their intercostals are weak, they're unable to take big breaths, or they're just debilitated in general, then a lot of times the pressure support isn't enough to allow them to take the tidal volume that you want. So how you know they're failing is I put them on a 10 of pressure support, and their respiratory rate went from 16 when they were on a rate to 40 when they're getting pressure support. They're taking short, quick breaths. They're not tolerating that. That's not good for them. So the one thing you can think is that we'll put them on volume support. So they decide they want to take a breath, and anytime they initiate a breath, I've set the volume support that the vent will give them. So I have made it that every time I decide to take a breath, you're going to get 450 mils of a breath, which is plenty for this young girl. So she doesn't have to work so hard to get that breath, right? So it's a way to start working and exercising the intercostals to get them breathing, but make sure that they're getting the volume. Now, if I extubate someone and they don't do great, I can't give them volume support back, so they're going to get reintubated. If I extubate them and they don't do great, I can give them pressure support, right? I can give them CPAP or even BiPAP if I need to. So it's a non-invasive mode that I can support them with. So if they're not tolerating pressure support, they're not ready for extubation, and I don't extubate. Now, the board answer for critical care is that you don't extubate someone to BiPAP or CPAP. That's the wrong answer. They weren't ready. But that's sort of the logic behind it. I can't give anyone volume support. So we were never able to get her off volume support, meaning even though she was trached, I could never get her to trach collar on her own. She had a retained hemothorax, and she had a lot of pain management issues. So ultimately, I did fix her ribs. But before I do that, when I'm preparing myself or setting myself up in the operating room, the things I need to know, I told you she broke ribs 2 through 7, right? Ribs 2, 3, and 4 are all underneath the scapula. I can't get to them very well. I can pull the scapula up and get to sometimes 4, but 5 and below I can get to. So it's tough. I had them take her initial CT and do what we call 3D recons, which the CT techs can do this, and you can see how misshapen and distorted her rib cage is. But it helped me know where to go, where to make my incision. So she got put up in a true thoracotomy position, the lateral position. We made a posterior lateral anterior incision. Oh, I didn't put her x-rays on there after I plated her, but I plated 5, 6, and 7 on her. Again, no indication. And the other indication that I actually went back for was because of the retained hemothorax. When I plated her ribs, I washed her chest out at the same time. I still think, even though her ribs look like that, I would have been hard-pressed to talk me into rib plating because I was very bitter with it by this point without having another indication to be there. Antibiotics, not really necessary, again, unless you have some gross contamination, and she got some chest tubes. This is a picture of a retained hemothorax. So what you see here is a retained fluid collection. This little squirt of right here is her lung that's collapsed down and trapped into that, and this is empyema. So when you see a rim-enhancing fluid collection, you see how you can see this white rim right here with air pockets in it? That's an abscess until proven otherwise. So this is an empyema, so washed out with lung entrapment, so her lung couldn't re-expand. All right. I did not do a good job about getting you out early, sorry.